the first lateral x-rays way the machinery goes on. When I do these cases, I like to have the patient fluoro to be anatomical to what I'm seeing on patients. That's why I do the mirror image. And I rotate so the disc space is just the way I'm looking at the patient. X-ray again. So the first thing we're going to do is mark out the disc space. X-ray again. So the disc space is going to be about right here. And so I'm going to make sure that we're going to be able to approach it down here. The other way to do this, if I'm going to do, say, a lateral incision for a lateral lumbar fusion, if I trace that incision down, that's about typically where I'm going to make this incision. So here's the crest, and then I can sort of feel roughly where the lateral rectus is. And if this is the crest here, I know I'm going to have to be medial to that. So my incision is going to be somewhere right in here. Lateral to the rectus, inside this crest. Typically, I use my incision about 1.5 inches on this cadaver. I'm going to be doing it a little bit longer, just because the tissues aren't quite, scalpel. So we'll start very simply with a nice, easy incision. And this patient's got a little bit of subcutaneous fat, but not too bad. We're going to go down to the fascia. So we've just gone through the fat here. And typically, as I just mentioned, I usually do 1.5 inch incision. Juan was asking me how long of an incision I make. On the cadaver, we're going to make it a little bit longer. Where's the scalpel? So now then we can see the lateral, the fascia of the oblique musculature. And typically, the fiber's running this way. I'll make my incision in the fascia along those fascial lines because I think it's going to end up healing a little bit better. As we see right here, then it opens up fairly nicely. Now there's going to be two layers of the fascia here, so when you close that, you want to make sure you get both layers back so we don't get a hernia. Now there's the lateral oblique fascia. So typically, just like in a lateral case, I'm going to go simply with my scissors and start splitting the muscles, and immediately we're going to see that bright yellow fat of the retroperitoneum, and that's all we're going to see right there. So right there, I don't know if you all can see the retroperitoneal fat in here. So there's a retroperitoneal fat after we just split the muscles simply. The next step is I'll take the retractor out, and just using my finger doing a digital dissection, trying to make sure we sweep the retroperitoneum down, and I'm going to want to feel the psoas muscle. So I'm just making sure all this tissue is coming down, staying out of the peritoneum, and my finger now is on the psoas muscle. You may actually be able to see it in this case. So right there is the psoas muscle. I don't know if you can see it down in there. And the next step, I'm going to come out with my finger and feel for the sacral promontory, which is a very easy landmark. It's easy to tell when you're on it. And at this time, I'm going to be using my finger to feel for the pulse of the iliac artery and know that the vein is going to be right underneath that, but that tends not to be something you can palpate. And then if I want now, my finger's right on the sacral promontory. So a lot of times I'll use an endoscopic peanut. So let's take an x-ray. So you can see we're a little lateral, not on midline. So right here should be the sacral promontory, x-ray. And so we're right there. So now we're going to go ahead and use a retractor. We're using the Medtronic's retractor. I call this the BFR retractor, the big frickin' retractor, but it works quite nice. So the first, I'm going to put in the superior retractor. We can put the lights on, which makes it very nice so I can see what I'm doing immediately. Making sure, again, the peritoneum is intact. And you can see there's still some peritoneum right there that I'm just trying to free up. And there's the psoas muscle again. So that's our initial set of the retractor. So I'm going to need a little bit of help. Somebody needs to kind of just baby this with me as I... Okay. Okay. Yeah. And this retracts a little persnickety, but once it gets in, it's actually quite nice. And it's nice it's got the light sort of attached into it. So we'll just start that there. And one of the things you want to make sure you do, you want to make sure the retractor is out of line of the x-ray. Give me a quick x-ray there. You can see that our retractor now is lateral to the disc space. So the vessels right now are medial to this retractor. I'm sorry, we're hoping the vessels on the left side are behind this, and the vessels on the other side, when I put this next retractor, be behind it as well. However, that's not always the case. So remember that you've got great, big vessels in there, especially the vein. Well, the artery is easy to repair. You definitely want to stay out of the vein. That's a horrendous thing to try to repair. So I'm going to try to get over on this side for a second. And now then I usually use a Kittner or an endoscopic peanut again to start trying to just see if I can find that sacral promontory. And there's a vein right there. And that's the vein that goes up. I don't know if you can see the dark vessels right there. Can you see that? Yeah, maybe go in a little bit. So I'm going to make sure I get all this adventitious tissue free and keeping the peritoneum intact. So I'm going to put that there, and this retractor is going to go right over top of that. So now then, using this distal retractor, we're going to start pushing down to try to get to the other side. And right there, I think you're going to be able to see the presacral artery and vein a little bit. And really, the retractors do most of the work for this case. And as Juan mentioned, a lot of times we hope not to see the ureter. However, you certainly can on occasion. So again, we're going to attach this retractor here. Make sure we're on. And now this retractor, I'm trying to scoot underneath all this adventitious tissue to the other side of the, so we can get a nice view. Give me an X-ray there if you don't mind. And so now this one is certainly in better alignment. Now I'm going to take that little Kittner and see the vein here. Now this is what you got to be careful. Sometimes there's little veins attaching this to the iliac, ascending iliac artery or vein. We're just going to push. If I see the presacral artery or vein, I'm going to coagulate and cut it. If it's more than 1 millimeter or 2, I'll put a surgical clip on it. If it's less than that, I'll just use my bipolar. And one of the things you got to be careful of in real time, sometimes if you put your retractor right over the vein like this, it can actually cause all the blood to go out of it, and you can't see the vein. You think you're safe. You will cut it, and you release the retractor, you can get torrential bleeding. So you really want to make sure you know exactly where the vein is as you go. And again, I'm using a retractor to do a lot of the dissection. And with that, you can now see very nicely we've got the entire anterior disc exposed. And this is really about the same amount of time it takes in a live patient, unless you're having issues of some sort. I would say that usually I only use two retractors. Occasionally I will use the third retractor if necessary. Largely in just fat people, sometimes keep that vein out of the way a little bit, and that would go in there like that. I don't think we need to put that in today. And again, you want to make sure, if I think this is where the retractor can be, if I'm happy with the retractor, before I start my work, I am going to release this just so I can see the vein as it fills up, make sure we're not cutting it. Because right here, if I have the retractor like this, right here is the vein. And it's hard to even see here in the live patient. I don't know if you can see. Can we change the retractor a little bit? I mean the light a little bit? So right here, if you're not careful, here's the vein right in here. And I'm telling you, in the real patient, if you're compressing that vein, there's no blood in it. It's very easy to miss that. And you can imagine you don't do your operation, you're so happy, and you've got a big laceration of the vein, you're going to be in trouble. Now, let's say you get a little bit of venous bleeding. You do not panic. If I got it during this approach, what I would do, I put a little Surgicel or something on it, on the vein, and then I'll take it and make sure that Surgicel is behind the retractor and the vein, so I can get a real good view there. And here you can see that it looks like there's a little bit of a presacral artery and vein. And there now we're all the way across on the other side.
So it's easy to expose
the downside is simple typically, but again, look at your pre-op x-rays. Make sure there's no signs of scarring or adhesions down there. Now, I think you can actually do this case as a reoperation for anterior procedure if somebody's had some sort of interbody, but you got to be very, very cautious. You may not be able to get this much exposure. Now, once you have this exposure, you can imagine then, it's just like any other operation. You're going to make your incision. You can hear the presacral artery we're going to cut. And I don't know how much we need to do here, but you can see that the operation itself is pretty straightforward. One of the difficult things, though, is getting midline. So one of the things I will do, let's come around to give me a true AP now, is that when I operate, I actually like to have the patient turned away from about 15 degrees, so ergonomically it's just a little bit easier for me. But then you can imagine that the understanding of where the midline is may be somewhat difficult. So I always like to get a film that shows me exactly where midline is. And Juan wants to remind me that that's one of the reasons you might use navigation. So show me that x-ray there. So this, I think we need to raise your machine up a little bit. And one of the other things we can, again, we always want to make sure we have our films or x-rays and the retractor arms out of the way, which can be somewhat challenging from time to time. Okay, x-ray that. So what we can do is actually raise it up and give me an angle. So angle your C-arm so it's in line with the disc space. So raise your C-arm up, and we want to be at an angle something about like this, I think.
You see that? That's why navigation becomes very handy on this one, because having a good
Switch flag.
indicator.
There we go. Show me that now. See how that looks.
Say that again, Juan. What did you say?
This is when navigation becomes very handy.
Lower it.
In this level particularly, because what? The retractors are very hard to negotiate.
That.
The fluoro is complicated to put it
Lower a
in.
little
You just
bit
have
more.
navigation, you know exactly what the midline is and how things are going.
Can I come north just a little bit?
Doing a sort of an oblique approach that you're not used to.
Yeah, because
Show me that.
it's very hard to get in the midline at the initial. You don't
And there we can see the spine is processed. So show me that, x-ray that. And you can see my knife blade is just about at the midline. So I'll usually use a cautery or a knife to just show where I know it in that inferior space.
What a mess.
And men obviously be very careful using monocautery even for this little thing, because we don't want to give them retrograde ejaculation. Okay, you can go back to a lateral now.
Oh.
Do we have a bovie? Is this hooked up?
Oh my God. Yeah. But don't forget, you're looking to a master surgeon. This guy looks everything very easy. Then you go back home and you're like, it was not like this. You know?
Well, we'll talk about it in my talk a little bit, that when lateral surgery came out, there was a big argument whether or not we needed approach surgeons. I think not. Then when we started doing thoracolumbar work, do we need a thoracic surgeon? Again, I think not. The question is, by doing an approach like this, do we need to have an approach surgeon with this? And again, I think with proper training and understanding the anatomy, I think, again, not that we'll be able to do this as surgeons. So you can see here that the disc space is all exposed. I don't think we need to go through how to do the disc space preparation, but it's like anything else. And you can see in this particular case, we got a good 45 millimeters exposed here. So any size implant you'd want to put in, you would be able to do very easy. And this is actually, fortunately, a fairly small cadaver.
Dr. Smith,
Yes,
we have some questions for you.
please.
First question is, when you docking initially your first retractor, and it seems like once you open the incision, you swipe the retroperitoneum towards the floor,
Yes.
and then you put your first blade right there. Where is that blade coming? The one that is up in
Yeah,
your
so the
exposure?
first, it depends on how well my digital dissection of the peritoneum. So sometimes I'll put in my first retractor just to start to get me down towards the spine, and I may trap a little bit of retroperitoneum. So then when I put the next one down, the lower retractor, I'll be able to then start pushing it down. So sometimes I have to go back and forth like using the retractors as fingers, and may have to make that adjustment 5 or 6 or 7 times. In this case, we were able to get right down there. So what I would like to be able to do is put this initial tractor right medial to the great vessels on the left side in this case, but I can't always do that. And I don't mind if I see the vessels. Now, similarly, when we're done with our exposure, I'm going to release this, and I want to see that. I want to see the vessels, make sure there is no bleeding there. So I think you all can probably see that on the, can we adjust that a little bit? So here's lift the retractor, here's the artery, and here's the vein.
Mm-hmm.
So that's when I initially set my retractor. I hope to be there, but we can't define that. So
One
you have to
second. We
remember
cannot
that you
see
don't
it.
want to be too vigorous. Everything's blunt dissection, no sharp dissection unless you're looking at directly. And the only sharp dissection I really do here is after I coagulate the presacral artery or vein and then go ahead and cut them.
Yeah.
Realizing that we do have to retract this vein, sometimes I'll see little vein tributaries coming off the vein here medially. Those you're going to, again, coagulate and cut. And as long as it's less than a millimeter, I don't think you need to ligate. If it's longer than a millimeter, I'll use an endoscopic stapler that I can rotate. It just makes it a little bit easier to put it in there.
Yeah, Dr. Smith, and then I'm noticing when doing this approach that the blade that is going closest to the floor, so the down blade, usually retracts very easily and you go past the midline easily.
Absolutely.
Is the superior blade the one is really very challenging to put it, passing the
X-ray.
midline up? So how do you handle the superior blade? That is, to me, the most complicated. You see that right now on the screen, the inferior blade looks very nice. You see it's passing the midline,
Yes.
but the superior blade always is a challenge. How can you keep it up? And also, how you keep working in the midline, not going through the floor when you start dealing with the implants.
Yeah, so those are great questions. So one of the things you can see, the inferior retractor blade is, it's about 50% down toward the foramen. Now, what does that tell us? I can use a scalpel and cut the annulus safely to where that retractor is. And if we're going to do put in a hypererotic implant for a sagittal deformity case, it makes it much easier to get our distraction. On the upper one, certainly is where all the work is. It's the more important one, is where all the work is. So again, I don't know if you can see in here, we're just going to use this to shift up, and I'll push, and then as I hold down, try to retract it out to do sort of a toe-in maneuver and lock it in there. And again, we didn't see how the vein's not quite there. I don't know if you all can see that on TV. So there's a vein, so I'm certainly not happy with that. That's a bad thing.
So I'm going to ask you a question, Dr. Smith. So when you do an A-lift, most of the challenges are moving the left iliac vein, yeah?
Yes.
That's the big deal. Yeah? That's the big vascular injury deal. So what happened, for example, if you leave usually the left side of the patient towards the floor? It means like you're doing the access from the right. That way, the blade that dissects easier is the one closest to the floor. Maybe you can avoid the more frequent problem that is dissecting the left vein, since it's easier to dissect the lower one, the one that goes to the floor.
No, that's
I'm asking
correct.
that question. I'm not sure, but
No, I mean, you're absolutely correct. It's always that lower one is easier to get there. And I think it just has to do with gravity, where the vein is in relation to the body, and the patient being in the lateral diffuse position. I really don't have a problem getting that inferior blade across the annulus on the opposite side. The upper one is always more difficult. Now, again, look at your preoperative films. I've had cases where they've had anterior osteophytes that makes it extremely challenging to get the vein off that osteophyte. So sometimes that will limit you. You're not going to risk that.
yeah. So in other words, is what happens if you have shot for both sides, if you always do right side up, you think make your life easier, or you think doesn't
No,
make any difference?
I don't think it matters. I think it's because I've done some right-sided approaches, and it's always whichever side is superior, that's the side that's going to be more challenging to get. Again, I think it has to do with the anatomy, where you're you're fighting the crest with this retractor blade here. This one, there's no fighting. There's soft tissues in your way, so it makes it very, very easy.
Yeah.
Now, the other thing is, again, you have to mark midline, because if you don't mark midline with fluoroscopy or with a robot, I think you're going to be very, very challenged. One of the more difficult things in this type of case is getting your implant into the midline position. And I think the best way to do it is you start laterally, and then you're going to drop your hand as you push in whatever implant you're using. So you want to end up having the implant almost right angle by pushing down on the skin incision. And sometimes I'll loosen up this retractor blade once I have the implant in, so I can really make sure I'm at a true orthogonal position of the spine to get it in.
Yeah.
Early on, I was tending, just like an O-lift, what happens? We tend to drive the implant in, and it goes in towards that contralateral foramen. Yeah. And I did have one or two patients that had some transient L5 nerve root palsies, but they're just torquing too much on that contralateral inferior nerve root.
Yeah. Then the next question is: do you think making your entry incision on the abdomen, the lower that you do it, the easier the access, because you're dissecting the bifurcation from inferior to superior instead of jumping inside, or you think doesn't make any difference?
Well, I don't think it makes a huge amount of difference because, again, you're always going to be lateral to the rectus sheath. And where we made our incision here, we're probably about 1.5 centimeters lateral to the rectus sheath in this particular case. You could make it a little bit more, but again,
What about inferior, closest to the inguinal ligament, like a lower incision? So you can approach the bifurcation from inferior, not
that's
just in front like a regular way access surgeons do it. I'm just asking questions because
Sure,
know
sure.
that you're doing a lot of these ones and you don't use access surgeon. And to me, the goal is how can we take the access surgeon out of the equation in here?
Yeah, I'm not too worried about trying to get lower below the vessels. I want to make sure my incision allows me to be in line with the disc space in that lateral plane. So I don't want to go lower, I don't want to go higher. I use my preoperative fluoroscopy to judge where I'm going to want to put my retractor, my incision at the skin. That helps me. And again, I think that we do want to be able to, once we have our implant in, to drop our hand like that. And sometimes I will, again, just loosen this inferior blade so I can get a little pressure like that. And that's all you really need to have, I think. So, it's a variety of different types of implants that can work in this procedure, but you need to know where midline is. And I think if you don't mark it, I think you're going to end up having some off-centered implants.
Can you still do an ACR on this level? Can
Absolutely.
you cut
Well,
the ligament side to side and
Absolutely.
really
Now,
put a hyperlordotic
I'll
implant?
mention that a little bit in my talk, but so once I have this in, I'll distract the disc space after my implants. And I like to do a direct release of the posterior longitudinal ligament. We certainly release the ALL, that's part of an ALIF. And then I'll do the release of the annulus as far posterior as I can safely, as long as I know where the veins are in the great vessels. But I like to directly release the posterior longitudinal ligament with a Kerrison. Why? I've had enough patients that I tend to do a lot of degenerative scoliotic operations on elderly patients with some degree of osteoporosis. And I've always found that when I'm trying to I'll just put a retractor in and forcefully rupture a ligament. Many times the bones are weaker than the ligaments, and I'll end up rupturing the end plate or get a vertebral body fracture. So I want to make things as loose as possible so my reduction is as easy as possible, less stress on the end plates.
Bill, I have a quick question. Have you ever had to abandon a case or not start a case if the sacral slope was way too high? So in other words, the angle that you're coming at is so, to follow up with Dr. Uribe's question, so inferior to superior that you're working around the pubis or that low?
Yeah, I can think of two cases where, again, preoperative visualization is critical. That I've looked at the preoperative films, two patients, just so they were both women, that had a spondy that I said there's just no way we're going to be able to get in that disc space from an anterior approach, even using angled instruments. So I have not gone in on a patient and say I can't do it. Again, I think that we need to look at our preoperative imaging. Our preoperative planning is critical in this case as is in any anterior retroperitoneal approach to the spine. This is what we're talking about all today is anterior retroperitoneal approach to the anterior column. That's where the money is, in my opinion, and that's what we're doing. So again, look at your imaging. That'll get you out of trouble. The best way to take care of complications is to avoid them. Any other questions?
We got one more, and then that was great, Bill. Thank you.
Now, one of the benefits of the lateral approach is that we can use it in obese patients. With this procedure you're demonstrating, what is the highest BMI you would attempt it at?
I've never looked at the BMI not to do it. In my talk I've got a couple pictures of fat people. Because you're not going through the fat panic, you're actually, I might retract, the fat is all out of the way. And I found that the distance from the skin in the lateral position to that sacral promontory is never more than 140 millimeters. It's very similar to when we do a lateral approach to a transpsoas approach. That we don't get into that problem. The biggest problem you have with obese people is when they stand up, they have this big fat pannus over the incision, it gets moist, and I think there's a high risk of having some form of poor skin healing.